Hi, everyone. Today's guest is someone I'm so excited to share with you. Dr. Audrey Puentes is not only a board-certified OB-GYN, but also an intended parent who has personally experienced the surrogacy journey. That dual perspective makes her voice incredibly unique and deeply valuable for anyone navigating this path. Audrey brings a calm, thoughtful approach to what can sometimes feel like an overwhelming process. In our conversation, she breaks down everything from prenatal testing and pregnancy milestones to what intended parents can expect as they move from the fertility clinic to OB care. We also talk about delivery day logistics, skin to skin, discharge planning, C-sections, and more. Basically, all the things you may not even know to ask, but need to know. Whether you're just starting out or you're weeks away from welcoming your baby, Audrey's insight will leave you feeling more prepared, more empowered, and definitely more at ease. Enjoy! Me, you, and who? Who knew it would take more than two people to have a baby? In a world where infertility is no longer a taboo topic, this podcast will take you through all of the different aspects of surrogacy and egg donation through the lens of many who walk this journey in different ways. My name is Whitney Hall, and I am a two-time surrogate, now turned surrogacy coordinator for Egg Donor and Surrogate Solutions, the very agency I used when I chose to carry for two amazing families. With this podcast, it is our goal to help guide and support you as you learn about what it takes to grow a family in an alternative way, as well as hear inspiring and beautiful stories of how this path has changed lives forever. We can't wait for you to hear about just one more way happy families are created every day. Thank you so much for being here. I am so excited that I get to chat with you from this perspective.
Yes, it's very exciting. Very different.
Very different, but so fun. Yes. Okay. So for those who do not know, you are Dr. Audrey Puentes, a board certified OB-GYN in Texas, but you are also a recipient mom and are currently a intended parent who has walked this road personally, which is so amazing. And I got to be lucky enough to be your coordinator the first go round. But can you just share a little bit about your own family building journey and how, just how this has kind of shaped the way that, you do your work now?
Yeah, so we started our journey in, 2018. We got some news that I was not going to be able to carry my own baby. We found out it was due to cervical, like an early cervical cancer kind of thing. So it was sort of an immediate process. It wasn't due to fertility concerns. And so it was kind of an abrupt diagnosis. So I ended up having a hysterectomy a couple months after that. So we knew early on that surrogacy was going to be the way that we were going to need to build our family, which was new, and it was kind of daunting, and really just a little overwhelming, I think.
Yeah.
And being an OB-GYN, and my husband's an anesthesiologist, so we kind of were familiar with how things kind of go. So we were aware, and I'm not going to lie, I drug my feet a little bit. But we did reach out to the fertility clinic that we were working with, and your agency was who they recommended, one of two, and we definitely fell in love just with, speaking with you guys and everything. So we did go there, and we actually were very, very, very lucky, and were matched with a wonderful gestational carrier. And we went through a very again, I know not everybody's journey is going to be as quick and as easy as it was, but we went through a beautiful.
It was pretty breezy.
It was
pretty
so
great.
breezy. And as an OB-GYN, as an OB-GYN and medical professional, we always kind of have this, not saying, but just this feeling that things just don't go right for us. Nurses, labor and delivery nurses, labor and delivery doctors, we just know things aren't going to go well. You end up with all kinds of crazy things happening, and ask any labor and delivery nurse, and it's like, yep, this is going to happen. So,
sure, absolutely.
So we were waiting for everything, but everything just went beautifully. I even got to deliver my son, which was really cool.
Oh my
Um,
gosh, it was the
and so
greatest.
it was beautiful. It was such a great experience. But, and so we walked that whole path and everything. We had a very supportive, work environment, very supportive, gestational carrier and her husband and her family. And so we
Mm-hmm.
really, really went through that. And, the agency was great. Our coordinator was awesome.
Oh.
Um, and also, it kind of dealt with us, being a little like spacey, just with our schedules and everything. So, but then, we have a beautiful son, and he's going to be 3 in a couple of months. So
Can't
that's,
believe it.
yeah, I know. And he's the Spitfire. So, so yeah, that's kind of us in a nutshell. And I guess a long nutshell.
Yeah, yeah. But I mean, again, like I kind of love even the fact that like you and your husband are both like in the medical field, that there's just still that very humanness of like, sure, we know everything, or we kind of know medically kind of where we need to go next,
Mhm.
but the very humanness of just, and we're going to still drag our feet a little bit, and we still
Yes.
need to adjust, and just all
Yeah.
of that.
It was, and I did. I felt like, because you still have those emotions, you still have
Yeah.
those feelings, and and then because like starting a family, with using a surrogate and using a gestational carrier, this process, like it's not as organic as the normal, the natural way, basically where you have to make choices, and those
Mm-hmm.
choices are big choices,
Yeah.
and it's you have to decide, okay, today I'm going to go to the fertility clinic and talk about egg
Sure.
retrieval. Okay, now we're going to decide that we have to reach out to, an agency. Okay, now we need to make the profile. Okay, now we need to do this.
Yeah.
And if you're any kind of nervous or not ready or anything, it is going to put that block there. And
Mm-hmm.
it is a little bit, daunting and stuff. Like, am I ready for this? And so it does. I mean, you need to do it. It's just whether or not you're ready for it. So that was
Sure.
definitely something I think that we were kind of, I think, drag our feet out. Not that we didn't want it, but it is, it's a little nerve wracking. So
Absolutely. No, for sure. For
I think
sure. And not for anything, but I mean,
yeah.
you're in a world of
Mhm.
babies constantly. So
Oh
I
yeah.
mean, yeah,
Yeah.
there's so much, there's a lot that I feel like you're
Oh yeah.
having to just navigate.
Oh yeah, absolutely. 100%.
Yeah, no, for sure. I
Oh
think it's so I always feel like when it comes to, once you kind of dive into the world of third party,
yeah.
a
Hmm.
lot of intended parents are, they're pretty confident whenever with their surrogate when they're in that fertility stage, because a lot of intended parents have done it, themselves, or they've
Hmm.
had to they've dealt with the clinic at least prior to the surrogate being there, so there's a lot of confidence with like the fertility stage. But once your surrogate becomes pregnant and they're released to OB
Hmm.
care, a
Hmm.
lot of intended parents aren't always sure what to expect.
Oh yeah.
So I guess, kind of my first question to you when it comes to, just that part of,
Hmm.
your journey, what would maybe be some of those good questions that intended parents can ask at that like first OB appointment, just so they feel informed and included and connected?
Yeah. So I think some of that actually comes before. So,
Yeah.
before you go to that first OB appointment, I think it's going to be important to, number one, you want to make sure that the doctor that that your carrier is seeing, that doctor is supportive.
Mm-hmm.
And if they have done, or have taken care of surrogacy pregnancies, and if not, is it something that they're willing to do? And
Yeah.
if the hospital, and you guys are really good about kind of vetting, the hospital and whether or not that's something that they're comfortable with doing, um, because the next step is, are you going to be at that appointment? So are
Mm-hmm.
you, as the intended parent, going to show up to that first appointment?
Yeah.
And the reason I say that is because a lot of times that first appointment isn't the first time you've seen your baby. So you've seen your baby at your heartbeat check. Typically you've gone
Mm-hmm.
to that heartbeat check and you've been released. So that typically happens around 9 to 10 weeks, is when you're being released over to that OB, to
Mm-hmm.
your first visit. So, so right now I'm taking care of two separate surrogacy pregnancies, and neither of the intended parents have come to the very first appointment.
Okay.
So, and that's a personal choice. And
Yeah.
so, the questions I asked, or I personally, as the physician, said, are they going to be coming? And so you need to talk to your carrier and say, listen, do we want to come to that appointment? So, number one, deciding whether or not you're going to come. And I think that's a good place to start. So when you decide to come to that appointment, whether it's the first one or the third one, is going to be, asking, are you comfortable, Dr. Smith, are you comfortable, with me calling, or, calling and leaving messages to ask, or how can I get information about the pregnancy, if I want something, to ask, if I want to ask a question.
Yeah.
Because sometimes, like I've done it where I did, but it's a little different for me because I was a physician, but I advocated for something that my carrier, was not really afraid to ask, but I felt like she wanted to ask, or it would make her life a little easier.
Mm-hmm.
And just kind of asking that, what is my role here? Like, how is information going to be shared with me? And so that's kind of the one of the first things. Finding out, in the event of an emergency, how am I going to be notified if my carrier can't talk? Like, what if, something's going on? Are you going to be
Yeah.
okay and comfortable calling and talking to me? And so, those are kind of the little things, like, what is my role here? And being able to feel like, am I going to be able to be included? That sort of thing. I think just I think finding someone and making sure that that physician is the first thing, is making sure your physician is going to be, okay, having that relationship, I think is the most
Yeah.
important thing.
No, I feel like that's huge, and not for anything. I mean, we'll cut to the, like, as far as the legality is concerned, you're going to have that HIPAA form and everything. But I do feel like when it comes to communication, there's kind of this. Not everybody knows how to handle it because now everything's a portal, and I'll just send you a portal message, and a
Mhm,
lot of times, you know that, oh, I need to talk to the intended parent, but
mhm,
once, maybe your nurse doesn't know, or your nurse does know but they're not there that day, or
mhm, mhm.
however that works.
Right.
So in your situation, I guess with
Mhm.
your two, how is it working right now with, the community, as a physician right now, how's that communication working, just as an example?
So the two that I have, they're actually, the gestational carrier is communicating with the intended parent. And in a couple of situations, the intended parent is sending like text messages to the carrier, and then she's screenshotting it and sending it through the portal.
There you go.
Um, and so that's been how it's kind of working. But I have said from the very beginning, if they want to call me and talk to me, just send me a message and say, hey, is there a time after clinic that we can call and discuss? I would be
Yeah.
happy to do that, because it's very different. Again, like you said, with the patient portals, like it's going to be in the carrier's name, not the intended parent's name. And
Right.
so any lab results are going to go through, and they're going to go through to the carrier. There's, the intended parent's name is not going to be on it anywhere.
Right.
And even like scan documents, I know with our system, like even scan documents, even if it did have the intended parent's name on it, it's going to get lost into space because it won't have a place to go. Like there's,
Right.
with AI and everything. So, um, basically making sure, hey, listen, like when lab results come through, um, how am I going to get that information? Am I going
Mm-hmm.
to rely on my gestational carrier to take care of it? Um, should I call and ask for that? Find a way, and a way of communicating that you feel comfortable with, because your doctor should feel comfortable with that, and also should understand the type of pregnancy that this is,
Yeah.
and that you're not being, it sounds terrible to say, but you're not being overbearing. This is your kiddo, this is your child in
Yeah.
there. And it is hard because you don't necessarily have control of what's going on. And you are expected to be asking these questions, and be a little nervous, and that's okay.
Yeah.
Um, so those are kind of, basically knowing what their comfort level is taking care of it. And I think some of the that's going to be the biggest thing. Um,
Mm-hmm. Mm-hmm.
Knowing how frequent the appointments are, and then asking what appointments are the big things going to happen. When are we going to have ultrasounds?
Mm-hmm.
Um, when are we going to do, when would I expect lab work to come back? When am I going to be getting information?
Sure.
Um, those are going to be the big ones. So kind of having a timeline of when to expect things would be
Mm-hmm.
helpful. Finding out if you can be on FaceTime or on the phone call during those
Yeah.
appointments if you can't be there, because some offices don't allow that.
Mm-hmm.
That's going to be a big one. And also recording of ultrasounds. I will say that even in our surrogacy pregnancies, our ultrasounds, you can't record them.
Mm-hmm.
Even mine, even when I went to my our ultrasound for the anatomy scan, they wouldn't allow me to record. And I'm an OB-GYN, so
Right.
I'm
Yeah.
like, okay. So they wouldn't allow me to record. So, and it has to do with HIPAA violation and things
Mm-hmm.
like that in case somebody else's name popped up and stuff. So,
Right.
making sure, finding out what you can do. Can your carrier call you during the appointment?
Mm-hmm.
Can you, if you're not able to be there, can you do can you do FaceTime? Would that be okay? Finding out for those appointments, because you're not going to need to come to all of them. I'm not going to lie. Like, it's, if you want to come, great, do it. But there are going to be some where it's going to be heartbeat check, answering questions, checking in, and then that's it. And they're very
Yeah.
short appointments. And if you live a distance away, then it might not be something that you necessarily want to do.
Sure, sure.
Those
And
are
I
kind of
think,
some of
I
the big
think, and sorry, I don't mean to interrupt you,
go
but
for
like going back to, just that, again, that communication level and things like that. I feel like this is such great advice
it.
to ask the OB prior to that first appointment,
Hmm.
because then I think it really gives intended parent, surrogate, and their coordinator that opportunity to kind of figure out, what does feel good as far as
Right.
communication, because I think a lot of intended parents really struggle with exactly what you said. I don't want to be considered, quote, overbearing, but again, to your point, it
Hmm.
is your kiddo. That OB is your doctor too, and you do get to ask questions. It's not
Hmm.
overbearing to want to know, when you say labs, what does that mean, and
Yeah.
what are we looking for, and
Hmm.
just things like that. That's not overbearing, that's just
Oh
wanting
yeah.
knowledge.
Oh yeah. Absolutely. And when it's going to be a little bit different than the person that is carrying the baby, because it's a little like she's going to have sensations and things like that
Sure.
that maybe she's experienced before, so she might not worry about the round ligament pain, and so she might not ask about that, and so there's going to be things that she's experiencing that she's not going to ask about, and that's okay.
Yeah.
To you hear her say that and you're like, oh my gosh, like, is that okay? And that might
Sure.
be something to say, oh, is that fine? And it's I almost kind of compare it to maybe a dad that doesn't really know much.
Sure.
Like, I'm sorry, dads out there, but it's true. Every now and then
It's
we
true,
have
sure.
it like, is this okay? I'm like, yeah, man, that's fine. It's just, and just like, he's all worried, she burps and he's like, oh man, it's kind of the same thing because you're nervous. Like, you've never, if you've never, if you're now, if you're an intended parent that has experienced pregnancy before, you may not be as, little, kind of nervous, but you are going to
Sure.
be nervous because you don't know if that's a normal sensation or not. You just want to make sure that everything is just perfect.
Yeah.
And I think going into it, again, being a physician taking care of someone, this group of patients, basically, we expect that. We
Yeah.
expect a really nervous, potentially very nervous, very excited group set of intended parents. And then
Yeah.
we also have, possibly a nervous, gestational carrier because she's, carrying someone else's kiddo. And so we've kind of got this like very special little situation. And I
Yeah.
think, again, before. That's a big thing, like we talked about, like you mentioned, really ahead of time, knowing that physician that's going to be taking care
Mm-hmm.
of the carrier is in this pregnancy is going to feel comfortable with that, and
Yeah.
know and spend the time with that family, and
Mm.
that. So I think that's almost like preemptively before you even get to the what do I need to know question,
Sure, sure, absolutely.
Mhm.
No, I think that's so great.
Mhm.
When, again, kind of, when you go back to the fertility process, right? Like there are so many appointments. There's lots of blood work. There's ultrasounds. There's constant updates. It feels like, you're like 10 times a day you're hearing from someone, and
Yes,
then suddenly, the care transitions to an OB and that pace totally slows down.
it does. It's like a huge break.
Yeah.
Um, and it is, and that's even for, patients who've gone through IVF.
Mhm.
And we could, so, that very first part of the pregnancy, you're going to be seeing your OB every 4 weeks. So you do every 4 weeks until you hit, and this varies a little bit, but every 4 weeks until you hit around that 28-week mark.
Mhm.
At 28 weeks, that will then transition to every 2 weeks. And then at approximately 34 to 36 weeks, then you go weekly. So that first chunk of time, I mean, you're
Yeah.
going every month and you're thinking, oh my gosh, like, are you sure? Like, I don't need to be going sooner. But there's not, and this is where it kind of comes the reality of pregnancy, right? At the beginning of the pregnancy, there's really not a lot that as an OB we can do to kind of change and, you know, change how things are going. It's
Sure.
going or it's not, right? And so baby's growing. That's
Yeah.
baby's growing, baby's developing. And, a lot of times, we're not starting to feel movement.
Mhm.
Usually we start thinking maybe around 16 weeks. As somebody who's really had a few kiddos, I don't start worrying, even for like my first time mamas at like 22 weeks, I have some girls who don't feel anything. I'm like, it's fine.
There you
Um,
go.
but so at the beginning, you're not seeing, that, so those nerves really do start building, especially for, some intended parents. They're like, is everything okay? So then it really comes down to, I know for us, like I felt like our carrier, she's a sweetheart, would tell us like, oh, I'm craving this, I'm eating this.
Sure.
And so then it becomes more of like the little stuff in between, like the non-medical stuff that you'll be
Yeah.
getting. But that pace really, really does slow down. I know and that'll come different, it'll be different for everybody, but I know every doctor is different. I know for us, we were sent to high risk because of the way that the embryo is formed.
Mhm.
Certain doctors, there is a little bit of an increase in cardiac defects sometimes with our ICSI babies, and so some will take that little bit of an increased risk and go ahead and send you to high risk, which
Mhm.
will then maybe increase the frequency of those appointments early on. And it just depends on the physician. I send my girls to the high risk doctor just because that was what was done for us. And I feel like
Yeah.
I would want that. So we still do that. It gets them in, make sure that, we get that checked out and everybody can kind of just say, okay, we're all good.
Mhm.
But it's, like I said, it's different for everyone.
Right.
But yeah, those early appointments, it really does kind of slow down because now we're in the hard part is at the beginning. The hard
Mhm.
part is getting pregnant and staying pregnant through that first trimester. And then after that, we're just looking at a nice, beautiful pregnancy, hopefully, right? So,
Yeah. I
and that's
think
a hard thing to swallow.
for sure, for sure, because I think I was gonna say, I think you kind of, as unfortunate as it is, like you said, OBs in that first little bit, there's not a lot you can change
Mhm,
about, what happens in those first,
mhm,
little weeks. And you can have as many ultrasounds as you want,
mhm.
and it's not going to necessarily change an unfortunate outcome.
Yep.
But there are things that you're monitoring.
Yep.
There are, all of that's why there's, hey, how are you feeling? Is there bleeding? Just like all of those things. There's blood work and all of
Yep.
that. But
Mhm.
going every day or every week isn't
Mm-mm.
doing much. There's not much for
Yeah.
you guys to do.
Yeah, exactly. And that's such a hard thing. And that's even for just anyone who's not going through this process.
Mm-hmm.
That's a very hard pill to swallow. And, because there isn't really a lot. And I always tell my patients, I was like, there's nothing you can physically do at this point to
Yeah.
change, to make this not go well. Like, just keep living your life, doing a really good job, eating really well, drinking lots of water, and being happy and hopeful. And that's like the best thing that you can do. And so, me doing an ultrasound, yeah, every 2 weeks, it's might make you less worried, but it isn't going to fix what's going on. So it's such a hard thing, because at the beginning, like you said, those appointments, boom, 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 because we're checking lining thickness. We're doing all
Right.
those things. We're checking, you're used to, when you're doing the egg retrievals, for like, for IVF and stuff, you're doing all of those things because there's a purpose to every single ultrasound. And
Sure.
then as we get further, that purpose of that next ultrasound is to make sure that everything is forming well, make sure we have good anatomy, make sure that heart is looking good, make sure that brain is looking good. We don't
Mm-hmm.
see that really well until 18 to 20 weeks. So
Right.
it does
Right.
take some time, because you don't want to look too early, because things look a little funny.
Sure. Oh gosh,
You're
yeah,
like,
for
"Oh,
sure.
no."
So, okay, so with that said, what are maybe kind of those routine screenings and check-ins that kind of happen in that first and second trimester that can be expected with a typical, pregnancy?
Yeah. So if everything's going nice and normal, so you've had your carrier screening, likely, like the intended parent. So they've had their carrier screening. So we likely aren't a carrier of any sort of genetic abnormalities.
Mm-hmm.
Now,
And that's that NIPT test and
so
like all of that
yeah,
jazz.
so the carrier screening is testing mom and dad.
Oh,
So
your genetic screening. Sure, sure,
yeah,
sure. Yeah.
so you've
Well,
had
we're
that.
going way back.
We're going way back. So that's typically what some parents will do. So that's already been done. Then we have the, depending on if the embryo has been tested genetically, so the PGT testing.
Mm-hmm.
Some parents opt to do that, some parents don't. It depends on the fertility clinic. Then comes the next step. Some OBs will still recommend the NIPT testing,
Mm-hmm.
which is additional, like, non-invasive prenatal testing. It basically pulls fetal genetic material from maternal blood. It's non-invasive. It's not like an amniocentesis,
No,
but
it's just a little blood test.
just a little blood test, and it tests for multitude of different things. Kind of our big ones, like the different trisomies, so extra chromosomes, 21, 18, 13. They test for Engelmann's, Prader-Willi, so just a big multitude of abnormalities. And it is, again, non-invasive. So that's an additional. There are some. Like I said, I have a couple of intended parents right now. One of them was talking about potentially more invasive, but
Mm-hmm.
we opted not to. They opted not to do that as the best.
Sure.
But again, and then so that's kind of our one. That's the genetic testing. Then the next, around the 15-week mark, you can do an alpha fetal protein, AFP. I can never say the whole thing. I'm like all. So an AFP, and that can test for the presence of AFP in the maternal blood. If the value is elevated, then that can potentially show the risk of a neural tube defect. So is there a neural tube defect, meaning an opening in the baby's like spine,
Mm-hmm.
or like in the back of the head, so like spina bifida, or something with like the back of the cranium. And
Okay.
so that is something that some intended parents may choose to do, because that isn't something that is necessarily found with NIPT testing.
Mm-hmm.
Typically, we do see that whenever we're doing a lot of those ultrasounds early on. And so some parents will opt to do that. That is, again, around the 15-week mark. Not a lot of us are doing that as much anymore, simply because we are seeing those early ultrasounds, and they
Right.
are looking pretty like we're able to see those.
Mm-hmm.
So there's typically that. Again, if there is any abnormality with either of those, then we do, again, send a high risk maybe a little bit earlier, and then we'll be
Sure.
doing like an amniocentesis to actually draw, some fluid around the baby, which will then have skin cells that have been sloughed off, and that'll actually test for actual genetic material from the baby, whereas all the other testing, even the PGT testing, it's like a placental type of test, so it can have
Mm-hmm.
some different material in it that isn't necessarily could potentially not be from the actual baby itself. So
Gotcha.
there's a lot of science involved in that. But those are typically like NIPT testing, potential AFP testing. And
Mm-hmm.
then around the 20-week mark, between 18 to 20 weeks, you'll actually get an anatomy scan where then you're
That's the
looking at
fun one. That's
that
picture
is the
day.
fun one. And the precious one. That is the one that everybody wants. Um,
Everybody wants that one. We all want the photo of the baby sucking her thumb.
and
Like we
it's
all want that photo.
so cute. It is so cute. I'm not gonna lie. Hopefully, my high risk doctors aren't looking because I totally snuck a photo. They
I
left
love it.
they left a
You
room for a
have to.
second,
It's
and
so
I just took
cute.
that profile photo.
Absolutely.
Um, gorgeous. Best photo in the world. So, but yeah, so that anatomy scan. So what that is looking for, everybody wants it because they want to see the gender and they want to see the cute face, right?
Oh gosh, yeah,
But
absolutely.
in
Those are the highlights.
reality,
That's the good stuff.
that's the good stuff. So the anatomy sono is basically for, it's for other stuff. So we're looking at, because even if all of the genetic stuff is totally normal, you can still have a structural abnormality. So
Sure.
you can still have, an abnormality in, the kidneys or, the heart structure, anything like that. And so we're looking at, measurements inside the brain. You're looking at the measurements of the size of the head
Mm-hmm.
to get like a weight of the baby. You're looking at the heart, does the diaphragm, is it formed correctly? Is the stomach, do we have a stomach bubble? So we're looking at all of those different things, which, again, we're all hoping that everything forms nice and beautifully and perfectly. But that's what that appointment is really for. In
Mm-hmm.
addition, the beautiful, cute little profile,
Beautiful.
as well as the parts to make sure that baby is a boy or a girl. So,
Oh yeah.
yeah. But that's kind of what that part is for. So those are the big screening tests at the very
Mm-hmm.
beginning of the pregnancy, that kind of, to check the genetics. Now, again, we didn't do the NIPT testing because we had done the PGT testing. So we felt like that was sufficient for us.
Yeah.
And that's just going to be a personal choice if that's something that you guys want to do. Again, it's a blood test. So, it's not like it's something super invasive, whether or not you want to do it. It's totally up to you and your
Yeah.
the gestational carrier. More information is not bad information in this
Sure.
situation.
Absolutely. You mentioned earlier sometimes there's appointments that intended parents really don't need to go to.
Mm-hmm.
Why?
Um, because I would say that first appointment is going to be probably around that 12-week mark,
Yeah.
maybe 10, 12-week. That one's probably a good one to go to because, you get to meet us. But then, around like 16 weeks, we're going to listen to the heartbeat
Sure.
and say, hey, how are you feeling? You're good? Are you eating well? You're sleeping okay? And then that's probably going to be it,
It.
honestly.
Yeah.
They're very short appointments, depending on the weight. It might be a while. So some of those appointments, you're going to do your 20-week ultrasound. That one's a good one to go to. 24 weeks, again, not so much listening to baby. Hey, how are you doing? Are you eating? That kind of stuff.
Yeah.
You can go to those appointments, totally go to those if you want to. If you have questions, you can still go. But as far as like anything interesting or anything being done, nothing really out of the ordinary, just kind of a check-in.
Yeah.
Um, and it's more for, checking on the physicality of how things are going. And so, those are really kind of up to you. And again,
Mm-hmm.
it's whatever you want to go to, especially if you're
Yeah.
out of, like for us, we were out of state. So for me, I had to kind of pick and choose what appointments. I honestly, the only appointment I went to was the anatomy ultrasound. Um,
Yeah.
and that way I could, and then I get to spend the day with my carrier and stuff, which was really fun.
Yeah.
But that was the only appointment that I made it to because it was, it was about a 6-hour drive.
Mm-hmm.
To go. So to make it for it, and then for our new carrier, it's going to be about an hour and a half, or probably an hour drive. So I'll have to probably miss some of those as well. So
Sure.
you just kind of have to, pick and choose what you're going to
Yeah.
go to. And I think that's something to kind of discuss ahead of time. Like, hey, is the next appointment going to be one? Like, what are we going to do with that one? And that may be one just to like phone in.
Yeah. Well, and I was gonna say, I think that's so great.
Mhm.
I think that's so helpful to hear because I think a lot of people really struggle with, oh my gosh, I feel guilty, I can't be there, or this is how I'm going to be included in this, and for all intents and purposes, exactly like you said, I think I remember telling my intended mom, she felt so awful, and we were living in the same city, and so
Mhm.
she felt so awful. She was just like, this meeting, and I just can't get there, and I was like, I'm about to go pee in a cup. They're going to ask me how I am. I'm fine. It's going to take 5 seconds. Like, it
Yeah.
really is going to be okay.
Yeah. Oh, yeah. And like, so what I've done is, do you want to record the heartbeat? And I do this for all the pregnancies that walk through, and
Yeah.
like, oh, my husband had to leave to go to work or whatever, because the wait was kind of long. So I'm like, that's fine.
Sure,
I was
sure.
like, here, just record the heartbeat, so ask, like, can I record the heartbeat, and then that's something, because it's your kiddo. And I mean, I
Yeah.
did this, although I was terrible. I'm not even gonna lie. I would literally forget that we had an appointment that day. And I was like, oh, shoot, I'd have to run and tell my nurse, I'm like, we have an appointment. Okay, I have a patient in a room. If I may have to run out. And I was like, if my alarm goes off, come and grab me.
I
She's like,
love it. I love it so
oh
much. Yeah, yeah. Those
gosh.
reminder texts were good.
I was like, oh God, I gotta hurry. I gotta like run and sit out at my desk. And I'm like, yeah, everything is great. Yeah.
Oh, you're
Oh, yeah.
good.
Oh, I was like the worst. I was probably like the worst intended parent. I was like, oh God,
Stop it.
so
No, you were
pregnant.
not. No, you had trust in your surrogate. You knew she was doing everything just fine and that, like,
Yeah.
hey, it's going to be great.
I was like, just let me know how it went. Just let me know.
Yes.
Yeah, it was, and that I think is important again, because like, so don't feel bad if you can't make it to all the appointments, because it's not every appointment is going to be groundbreaking.
Yeah.
It is important to go to some, but like I said, out of the two I have, I think I've met one set of intended parents.
Yeah.
And then the other one, I don't think I'm going to meet until the delivery. And that's okay. Like, it's fine.
Yeah.
It's totally fine. And I said, listen, if you guys ever want to do a phone call before or after, just let me know. And like, we'll do that. And again, that's again where that communication between that
Hmm.
physician and you as the intended parents is going to be really important. Um,
Yeah.
and again,
Yeah.
like you're saying, like having that trust in your carrier and being able to say, listen, like, I know that you know to ask the questions, or even say, listen, can you write these questions down?
Hmm.
And I've had that before, like, hey, so the parents want to know, can I do that? Can I do this or
Yeah.
what? And you're like, absolutely. And you answer those questions. So, yeah.
No, it's perfect. And I think you kind of said this in the beginning, right? Like, maybe as a pregnant individual, they're not going to necessarily think to ask a certain question about a
Hmm.
symptom that
Hmm.
they've mentioned because they're used to having it. But,
Hmm.
it might be helpful for, mom or dad to just maybe have, well, do you mind asking,
Hmm.
the doctor about XYZ? And
Yeah.
that's totally fine. And, you keep
Hmm.
going back to communication. I feel like that's just the name of the game, just in
100%.
general with any part of this,
Yeah.
journey. But I think, again, intended parents, you have permission to ask these questions, and,
Yeah.
and having that relationship with the OB,
Hmm.
whether it's even if you don't see them until delivery day,
Hmm.
asking beforehand, hey, can I call you? Or are you willing to call me? Or what's the best way
Hmm.
to communicate is
Hmm.
just so vital,
Oh, yeah.
in this process.
Oh,
You
yeah.
mentioned delivery day. I was going to say, what are kind of how can how do you feel like you kind of prepare and support your patients, and kind of how did you feel, I guess, as you were also approaching delivery day, and you're getting down to those weekly appointments, and now we're starting to, maybe
Yeah.
we're asking about induction and what are signs of labor, and we'll,
Yeah.
or for our intended parents that are out of state, I know I always get the question, when should I go?
Mm.
And I'm like, talk to your doctor.
Yeah. Yeah. So, big thing is going to be finding out the history, the birth history of your carrier.
Yes.
And did she go early?
Mm-hmm.
Did she deliver at 39 weeks? Did she have to get induced? Um, find out that information.
Yeah.
Because if it turns out that she kind of went around 39 weeks or she went a little early, you might start thinking about potentially maybe planning on going a little early too.
Yeah.
So, um, you know, I advocate for induction
Mm-hmm.
for our carriers, simply because it's hard to plan. Um,
Sure.
unless you live in the same city. If you live in the same city and you're down the road and it's easy to get to, or you can get there in a short period of time,
Mm-hmm.
then you may not need to. Or, your job allows, like, yeah, I can just
Drop
pack
and go.
up and leave. I'm good,
Yeah.
then that might be something that, yeah, you can do kind of spontaneous.
Sure.
Um, but and obviously, if you want, that's a kind of something you want to talk to, you want to talk to the carrier about. Say, listen, like, are you okay with induction, or are we not okay with induction?
Yeah.
um and so, for us, again, like, me and my husband were both physicians. Like, I can't, like, if he's on call, like, he can't, like, if he's on, an OB call, like, he can't just be like, all right, well, I gotta go,
Sorry.
at 2 o'clock in the morning. Like, we have to plan it for us. And so
Sure.
that was something that for us, we really needed to have planned out. And so, we really were kind of saying, hey, would you mind being induced? Is that going to be okay?
Mm-hmm.
So as a physician, that's definitely something I asked. Are we okay? Hey, listen, your carriers are your intended parents are out of state.
Right.
Are you okay being induced? And then if the answer is yes, then typically we look at kind of like a 39-week induction. And then maybe talk about, hey, just in case, if you want to come in a couple of days early, a week early, then that's up to you guys.
Yeah.
Just kind of get planned, get the lay of the land, get a hotel room set up, that sort of thing. And so that's, if you're not going to be induced, then I would say maybe, figure out kind of where timeline that last delivery was at. Like, did she deliver at
Sure.
13 weeks? Maybe come in a couple of days before that timeline. So really kind of play that out, and really, again, like, ask your doctor. I think talk to the doctor and say, listen, like, what are my chances? Should I come in a little early? Um,
Yeah.
because you don't want to miss it, right?
Yeah.
You certainly don't want to miss it, and you don't want to be in a situation where, you're having to drop everything and you just can't
Mm-hmm.
do it.
No.
Yeah.
Yeah.
But yeah, I think planning it. So say that we've planned it, say we've got that 39-week induction going, really talking about what's the hospital like,
Mm-hmm.
what are my options? Like, what are we, like, that was one thing for us. Like, what is the setup going to be that day? Like, are we just going to be, hanging out together as a team, just in the same room? Like, what are we
Sure.
doing? So
Yeah.
again, like, I know this will all be discussed usually prior to, but finding out who's going to be in the room, talking to the OB and finding out how many people are allowed in the room.
Mm-hmm.
I will say that as an OB, unless it's a very strict hospital policy, which in usually this situation is kind of waived a little bit,
Yeah.
but just a teeny bit. What is, who can I have in the room? Who's going
Yeah.
to be in the room? Really kind of figuring that out. Like, I think with our delivery, her husband, like, was like, hey, I'm good. Like, not being there is cool. Like, I'm,
Yeah. If I remember right, I think she was like, it's really best that he not be. So it's
yeah,
really
she's like,
okay. Yeah.
it's fine. It's
Yeah.
fine. He was gonna be our photographer, because we had a photographer, and then she got COVID. And then she wanted her mom. Like, her mom was like the sole person that she wanted
Uh-huh.
there. And then she was fine with my husband being there and then me. But then her husband was going to be the photographer, and then he had to go pick up the kids because she didn't
That's
deliver as quickly as she
right.
thought.
That's
She was like
right.
all upset because she didn't deliver before 3:30. And I'm like, you literally have been here for like no hours. Like, it's the fastest delivery ever, but whatever. But yeah, so kind of figuring out, like, what our ideal room plan
Right.
would look like, right? And then
Right.
building off of that, because typically, or what we would like is, our carrier to have her, her space with her support people, and then
Mm-hmm.
hopefully have our intended parents have another separate space where they can kind of like go in and out and be there and go visit back and forth and stuff and be present
Right.
for like big events, things like that. We did not get so lucky. They didn't have an extra space for us, so it
It's
was
really
fine.
small.
Yeah, it's no big deal. It's a little hospital, and it wasn't a big deal. Honestly, the hardest part was they didn't have enough chairs, so my poor husband had to sit in like a wooden rocking chair from like 7 to 5. Actually, later than that because they didn't have a postpartum room for us until like 10. But so that was fun. But really kind of checking out like it was good. So, kind of looking and seeing like, okay, what is it going to look like? Are we going to have our own space? Like
Right.
realistically, most hospitals do try to do that. And like, again, like the agencies are really, really good. You guys are good about getting in touch with, the people.
Right. I was going to say a lot of this we usually like we
Yeah.
reach out beforehand and we kind of let
Mhm.
everybody know here's your protocol and
Right.
if you have extra questions, a lot of times you're able to talk to like a social worker type
Yes.
individual or the charge nurse and things like that.
Mhm.
But I think to your point, a lot of times the hospital will defer, especially in the event of like a C-section, they'll kind of tell you, oh, there can only be one person in the OR.
Mhm.
But that might be deferred to,
Mhm.
the OB or the
Right.
anesthesiologist or things like that. And so
Yep.
that's kind of where you can talk to your doctor in those events.
Yes.
And, exactly like you said, you can kind of prep, intended
Right.
parents and the
Yeah.
surrogate for that and things
And
like that.
and I think, for us, like, again, I've already kind of talked for my upcomings, like, hey, listen, like, we've got this coming up. What is that going to look like? And so my charge, I've already talked to a charge nurse and our nurse manager, and this, we're not even due for till the end of the year, but kind of saying like, this is how we do it. And they're like, okay, I really like it when, for instance, if it is in a C-section, the patient and their support person is at the bed, and then one of the intended parents is by the warmer, and so they're both in the room but they're separate, so it doesn't, nothing's in the way, but she's like, this is their baby, so they should be in the room.
Yeah.
And so there is that feeling in most hospitals, there is that feeling surrounding this type of a pregnancy because it's important, right? Like
Yeah.
this is your baby. So I think just kind of knowing that. So having those things kind of figured out a little bit and just knowing overall, really, it's at the end of the day, the hospital and the nurses, they're going to figure it out and help you. But
Mm-hmm.
you, as an intended parent, it's going to help you feel better having more of that information.
Right.
Um,
Right.
and then just knowing more, and you will have your own space after delivery, because she will be her own patient and then the baby will be its own patient, and so that baby will have its own room, so the baby will be admitted to its own room and you will
Mm-hmm.
be rooming in with the baby.
Right.
Don't be surprised if you don't get a meal because that happened. um,
That happens. That happens. Yeah.
It was
Yeah.
cute, but it is what it is. But you'll have your own space,
Yeah.
and so I think just the fun part about that is like preparing. Like, what's it going to look like? What are we going to feel like? And I think this agency does such a good job making sure and the matching everybody so well and doing
Mm.
those psych, those psych, consults. I say consult, but you know what I mean, like the,
Yeah, well, we have the psych evaluation,
the
but then
psych
we do
eval.
ask a lot of the questions prior to even matching and,
Yeah, and
talking a
it's
lot about that.
it's so nice because like you already kind of know going in what you're getting, and so you're not going to have those weird situations, and
Yeah.
that you have that. And it's a good thing to kind of go into, so what you're going to feel like I
Hmm.
already know where we stand, and we're not even pregnant again for the second,
Right.
what I mean, like I already know what it looks like,
Yeah.
emotionally, and as far as like us as a family and as a group. As far as
Hmm.
the hospital and stuff, I have no idea, but I know that it's going to be okay. I know that it's going
Hmm.
to work out.
Yeah.
So I think it's going to be the little minutia, who's going to cut the cord. Is it okay if my husband is here? Is it okay if he's here and he stands at those are going to be like the little things you guys like kind of figure out. But as far as like the medical stuff, as long as your doctor knows and communicates that with the staff
Mm-hmm.
outside of what the agency does is going to be really important. And so just making
Yeah.
sure that stuff is known is going to be important.
For sure.
Yeah.
Absolutely. Talking about kind of some of the medical sides of things, I know we do our best to, prepare intended parents, but typically like for a vaginal delivery,
Yeah.
what can, intended parents expect? What's kind of maybe the best spot for you to, stand, or I know in some, situations maybe you need to go and sit down, or,
Mhm.
that kind of thing. What does that usually typically look like with a vaginal delivery?
Yeah, yeah. So with the vaginal delivery, most units, at least the ones that I worked in several places, and so most of the time, you've got the bed, and then a
Mm-hmm.
lot of times, right off to the side of the bed, there's either a couch, a recliner, something kind of along the side, and there's like space. So typically, that is where family is put that doesn't want to see anything. Right. So and that's for every shape, form of family, right?
Sure,
Um,
absolutely.
Grandpa that somehow got wrangled into being there, like everybody,
You go sit on the couch.
intended dad, whoever, like they're all up there. So usually the head of the bed typically is the best place. Even head of the bed and looking down. So typically in a normal vaginal delivery, you're in a position as you see on TV all the time, you know,
Sure.
on the back, knees up. You can't really see the parts,
Yeah.
a lot of times it's just you got a big old pregnant belly. I mean,
Hmm.
half the time pregnant women can't even see their own toes. So certainly
Sure.
from that angle, you're not going to be able to see directly underneath that belly. So that's usually a good spot for anyone to stand if they want, privacy. So it does
Hmm.
typically is a good area. And so there is that good kind of space up to the head of the bed. And so that's usually good. Now, if for some reason there isn't a good spot like that, there usually is an area in the room where there's like a curtain or something where maybe the carrier says, I don't really want them there until the baby is out.
Sure.
There's always a little space where they can sit, and I'm not no matter what is happening. If they walk in and their baby is there, they are not even going to look. They're not even going to
It's
look at
so true.
like I mentioned before, like I delivered my son. My our doctor had me do that, and I don't remember it.
No,
Like
you
I
caught him. That's what you
remember
did. Yeah.
this, and then that. Like, I don't remember anything.
You're
Um,
right.
like, and I was there. So,
Right. Right.
and so, so at the end of the day, even if, they did walk in and they might get a glance of something, they're not going to remember it.
They're
They're
not
not
gonna
going to
remember
see
it.
it.
Yeah.
So, but that's a good spot to stand is like the head of the bed. And that's good for, for anyone who's like, okay, well, I want the family there, but I don't want them to see anything. Uh,
Right. We want to, modesty and
yeah.
respecting all that. Yeah,
And
that's a
that
good spot to hang out.
and that would be a good thing too. You can even talk to the nurses because sometimes the nurses are pretty. They might put a little blanket up over the knees or something and stuff. And there's always a good way to help with modesty if needed. For
Yeah,
sure.
for sure.
Mhm,
So
mhm,
baby comes out, and generally baby usually, like, GC, gestational
mhm,
carrier, kind of
mhm,
becomes like a table almost, and
mhm,
baby
mhm,
kind of hangs out there for a little
mhm,
bit. And about that time is whenever, depending on whether you're doing delayed cord clamping or things like
uh-huh.
that, that's whenever you start cutting the cord. And
Yes.
yeah.
Yes. And so that is also a question too. So depending
Yeah.
on how the GC's feeling, I did ask ours, are you okay if I put our baby on you?
Hmm.
Because I don't know emotionally what's going to be felt at that moment. Is
Sure.
that something that she's going to be like, I don't want, this child isn't my child. I don't want this baby. I don't want to experience what I maybe have experienced with my other kiddos. Um, she was totally fine with it. But, it might be different for everyone.
Yeah.
And so, if that's the case, that is again something to kind of put in like maybe even in words, or birth plan of some sort to say,
Mm-hmm.
listen, I don't want baby directly on me. And then that's something that as an OB, I know that I even have, mamas who don't want their own baby on them. They go, no, can you hold the baby and cut the cord and then go clean it and bring it back to me? That
Yeah.
happens. And so we know we can hold the baby and do our own thing and everything like that. So just needs to be something that's communicated, again, back with that communication. So,
Right.
but yeah, a lot of times, yes, the GC does become a little bit of a table. It's the easiest place to put the baby.
There you go.
Usually that's where the towel is, and that's where they do like the stimulation and stuff, simply because that cord is still attached and we're getting that good blood flow and getting that baby stimulated and everything. And that's a good spot. That's just a good spot for baby. So
Yeah, absolutely.
Random plastic bag drape thing. So
For sure, for sure. So after that happens, how you have a lot of intended parents who are trying to figure out, well, how quickly do I get to do skin to skin? But then, like you mentioned, there's a warmer and there's kind of some of those checks and things like that. What can an intended parent expect usually kind of in those moments?
Yeah. So that's going to be, again, I mentioned a birth plan. So that's something to kind of think about birth plan wise. If you want that baby literally to just kind of be like cord cut, dried up a little bit and gone skin to skin, that is up to you.
Yeah.
So we can either dry the baby off, take the baby over to the warmer, get vitals, do weight, wrap the baby up, swaddle, whatever you want, or we can literally just make sure baby's good, make sure baby doesn't need to go to the warmer for resuscitation for anything.
Right.
If baby's looking good, then put baby skin to skin. I mean, I put on a shirt that I had, it was like a skin to skin shirt, so I didn't have to like undress in front of people. And I just plugged it right on in there. But it just depends on when you want to do that. Typically, we'll recommend delayed cord clamping anywhere between 60 seconds to, I think it's 180 is where we kind of recommend that, just to get that extra blood volume to the baby, to just make sure we get that. Now, if you're wanting additional, delayed cord clamping, that's something to, again, to kind of put into a birth plan, to discuss that with the OB and everything. And that will be, but that's usually the time frame. But if you want to go skin to skin, especially, you're sitting there, you're knowing you're nearing the delivery and things like that, kind of preparing yourself, maybe wearing a shirt, as the intended mom or intended dad, wearing a shirt that's easy to either like break away or even putting on a hospital gown backwards so that you could bring the baby in. So that kind of stuff to kind of prepare ahead of time. And usually the nurses are pretty good kind of preparing you for that.
Yeah. No, that's perfect. So you guys, I know generally skin to skin, and then most of the time, we'll say 99% of the time, intended parents kind of go off on, to their room, and now they're having, that, and now surrogate is hanging out. What does discharge usually look like for a surrogate? What's kind of that postpartum care that can be expected?
Yeah. So if everything is going really well, it can be, I mean, as long as her bleeding is controlled, as long as her vitals are stable, it really varies for everyone. I think in an ideal world, we love a good 24-hour stay. But if surrogates like, yeah, my fundus is firm, my bleeding is good, I didn't tear, she didn't have any other comorbidities. I mean, I've seen moms go home anywhere between 6 to 12 hours. Because you think about these patients that deliver in birth centers and things like that, they're home 6 hours. So it really just depends on the status. I think a good 24-hour stay is usually a good place to be at. But, as long as a lot of times, the healing process, as long as that bleeding is under control, as long as we've, we're not, having a huge, terrible tear and, everything has been repaired well and you're feeling comfortable, that's really just going to depend on you. But as long as everything is looking good, I would say a max of 24 hours for a nice vaginal delivery.
Love it.
Yeah.
When can, a lot of times you'll have surrogates who are perfectly willing to pump for their intended parents, or, they definitely want, that magic colostrum and all of that. What does that typically look like? When can an intended parent maybe expect milk to come in, or is it, oh my gosh, baby's here, we need to immediately feed baby?
Yeah,
Like,
yeah.
what does that look like?
So that is another good question to ask the OB when you kind of during some of the visits,
Yeah.
whether the hospital does donor milk.
Great question.
So they'll be kind of depending on where you're at, they might kind of be iffy about it, but usually, the carrier will start be able to collect colostrum within that, usually the early that next morning, even that evening might be able to kind of get you. It's not going to be a lot. It's going to be a
No.
teeny tiny bit, but their little tummies are like this big, so you don't need much. Usually that milk is really going to start coming in within the next few days. I would say
Mm-hmm.
we're really looking at like, anything in a bag for at least 3 or 4 days for
Yeah.
sure. And so usually you're going to want, if they're going to start pumping for you, you're probably not going to get that for a week or so, if not,
Mm-hmm.
enough to be able to send, because they're not,
Sure.
unless they're coming to your house. But usually, you'll be able to, during your stay at the hospital, knowing that you're going to be transitioning over to pumped breast milk, be able to do some donor milk while you're in the hospital. Some hospitals will say, unless you're discharging and you're going straight to breast milk, they will want you to try formula just to make
Mm-hmm.
sure that that baby is able to tolerate that. So that will be something that you may want to consider, having some at home or having some ready,
Yeah.
or having donated breast milk that you have at home also ready for you if you only want to do exclusive breast milk, because it may take some time for your carrier to be able to get enough of a supply to
Mm-hmm.
want to be able to fill up a box. Because I'm not going to lie, it's a little pricey to get that box. Like the obviously the cost of the pumping, that is what it is, but the box and the shipping and all that stuff to get that figured out, it takes time, and it takes some.
Sure. You don't want to ship like just 4 bags. Like you want to really fill her up.
You want to fill her up, a good size little. You want to get that done. So
Yeah, for sure.
so you really want to make sure that's good. So, either have a plan in place.
Uh-huh.
And so if you think that you're going to want to do, again, exclusively breast milk, then you may want to find someone or somehow get some breast milk from ahead of time, or think about doing kind of some formula
Supplemental with the formula
supplemental,
and
yeah, and
yeah.
kind of going back. I know that's what we did, and then kind of we mixed that in a little bit, while we were waiting for the breast milk to come in, and that worked out really, really well.
Yeah, yeah, for
Mhm.
sure.
Yeah.
So going back just a little bit,
Mhm.
we kind of talked typical, vaginal delivery.
Mhm.
In the event, I'm in the fun club of scheduled C-section. So what is kind of, I know generally speaking, when it comes to C-section,
Mhm.
right, like that's surgery. So now we're in kind of a whole different ball game as far as, where you can stand and, all of those things.
Yeah. 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 So, for a C-section, either, so kind of one of the things I think to ask, and we can get into it whether you want to, if you want to or not, but there are going to be reasons for a C-section not scheduled.
Yep.
But in the event of a scheduled, or say that, hey, we just find ourselves in the OR. Okay, we just find
Sure.
ourselves in the OR. Typically, we have the operating table. There's going to be a big blue drape. You're going to see a little round belly with like nothing on it, and then this
Yep.
blue everything all around it.
So
So
much blue, so much
so much,
bright, and so much
so,
blue.
so much blue. Good thing is it's color coded, right? So they basically, as anybody walking in that is not part of the surgical team, they don't touch anything blue. So, ding, 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 we've got our check mark. We know what not to touch, right?
There you go.
So, they'll bring in, usually after, depending on the situation, carrier will get a spinal, or will get their epidural dosed up to make sure that it's
Hmm.
working really well. And then we'll get laid back, cleaned up, positioned, draped, and tested. Are you numb? Can you feel that? You're good. Awesome.
Right.
Then support person for the patient will be brought in, and so gets brought in. Don't touch anything blue, and will then stand behind the drape, at her head, and so That's to be support for the person being operated on.
Right.
Usually around that time, likely will be kind of a team. More than likely, everybody will be sort of in the same room together. So as they go to get her support person, the one of the intended parents or two, depending on the policy of the hospital or how things are going that day, will be brought in and will likely go to be around the warmer.
Right.
Whether the warmer is in the operating room or short, like right outside, that just depends on the hospital. Ours are inside the rooms. When I was in training, they were outside the rooms. It just depends on the facility. We'll likely go to the warmer. So, and everybody has to wear these really weird, like white bunny suit things. Yeah.
Yep, you're like head to toe covered, like yeah.
Mask, hat. Pro tip: don't wear anything really heavy underneath because it's going to be hot.
Yeah, you're gonna get toasty.
Even though you think you can see through it, it's going to be hot. So don't wear like a sweatshirt. Take your sweatshirt off.
There you go.
And also carry your phone in your hand and not in your pocket, because at the last minute you have trying to zip, it'll break and you won't be able to. So those are the two things. Don't wear anything warm, and don't wear your hand, your phone in your pocket.
Hold your phone. Yeah.
Hold your phone. So, the surgery will get underway. And then once we start getting close to baby, the anesthesiologist is really good about saying, hey, listen, we're getting close to baby. And so that'll be kind of like the notification to everyone, hey, this is about to happen, hey, patient, you're about to feel some sensations.
Sure.
And then also, baby team, things are about to come to you. We're about to get a baby over to you.
What's that timeline usually?
If it is a primary or first C-section, from skin to baby, usually less than 5 minutes. For a repeat, depending on scar tissue, it can be anywhere between, same thing, like a primary from 5 minutes to, 10, depending on what the scar tissue is like.
Sure.
Usually it's a very short period of time. It's finishing things out, kind of putting everything back together, that takes some time. So not very long. It's a very short period of time. And then the baby goes to the warmer, just kind of an alert. C-section babies don't always come out screaming and crying. Sometimes they need a little help. They were just, removed.
Sure. They were nice and cozy, and now all of a sudden they're not.
Yes. And especially if they were breech, this was not their intended, they were not planning this.
Sure.
They were sitting. And so it does, they get a little shocked, and they're not the criers. And so I always warn, everybody, hey, listen, they may need to be worked on for a second. That's okay. We have our teams in here for a reason. And so then they'll go over, and they're basically looked at usually by either a NICU team that has to come to the OR, or they're looked at by a labor and delivery nurse that kind of checks on baby. And there's certain scores that they're doing based in like how baby is, doing, checking vitals, that sort of stuff. And so that's usually all done at the warmer. And then once the baby's nice and stable, then that baby, the baby will be wrapped and everything. And then whatever the plan is for baby will be, done, like either goes with the intended parent, or if, the care would like to see the baby at that time, they can. That'll also, again, be a plan for you guys to discuss, beforehand, or do you want to just see baby, when you're in recovery or postpartum, like that sort of thing.
Right. And no, you cannot cut the umbilical cord because you are in a surgical zone.
Yes.
Just by the way.
Yes. That will not happen.
That will not happen under any circumstances. You don't get to just like reach in there.
No. Somebody will slap your hand away.
100%. Oh my gosh. No, for sure. So what advice, just again, as someone who, you sit in the seat now as, just a medical professional in this field, but then you've also, been the intended parent. What sort of maybe reassurance or like perspective would you want to give to, maybe some IPs as they're maybe, feeling anxious, or they're wanting to figure out how to be connected, but they're not sure, or, just as we kind of get to this part of, the journey.
So we're done. The baby's born. You're going to be connected. It happens. That was something that I worried about. I really did. because especially like my job, right? So I see moms, that baby comes out, goes straight onto her chest. She feels that immediate connection.
Mm-hmm.
I'm not a very emotional person. I've never been, especially with my job. I can't be, I have to compartmentalize a lot. So,
Sure.
I learned how to turn it on and off. And so that emotional aspect, I'm just not. And I said, well, how am I going to do this? I'm not growing this baby inside of me. I've also missed so many appointments, like I'm not feeling, the baby move. So I have this theoretical child out there, right? That I know I'm bringing home, almost felt like, sounds terrible to say, but I almost felt like it was like a puppy. Like I'm bringing home a brand new puppy. I was
No, I
excited.
think that's a great I don't think that's terrible. I think that's a great descriptor. It can totally feel like
Yeah,
that.
I was
Yeah.
excited to bring this little puppy home, right?
It's
Um,
like all theory.
yeah, I'm like, yeah, like if he's coming home, or like, is he gonna like me? But it is a different, bond, and you wonder, and you do worry as a parent, because you think, I have to grow this child inside of me for this child to feel like mine. And you're told
Mm,
that, and you feel that, and you think that, and you think, oh, it's the oxytocin that's going to make me love this child. And
mm,
you get that, you hear that, right? um and it's not true. The moment my son came out, I was waterworks.
oh my gosh.
Mm,
It's like the most.
pure waterworks. And I don't know where it came from. I don't
Oh,
know.
it was pure emotion. I mean, it was raw. It was
Yes,
raw emotion.
like
Yeah.
pure. And I'm like, what in the heck? And that, and it was that moment. And he has never not felt like my child,
Yeah.
ever, from that moment. I mean, I have a picture of him as a little embryo, and I'm like, but like the moment he came out and I saw his little face, I saw his head, I got it. Even when I saw his hair, I was like, okay, he's got dark hair. He. And then when he came out and he was in my hands, this is my baby. And there
Yeah.
was no question. And you don't think that, but even mothers that birth their own child sometimes
Mhm.
don't feel that connection.
Yeah.
That's okay, right?
Mm,
Even if that does happen to you and you don't feel it right away, that's also okay.
yeah.
But I don't think that's going to be the case, because so many of us that are going through this have had such a struggle to get to this point, whether it is a struggle of years of infertility, of
Mhm.
this huge desire to create a family, that just wasn't going the way that you thought it was going to, the way that, our family was, we just didn't have that chance.
Yeah.
There's struggles, right? And or even, say that, you're the way that you have to build this family is just different. It's a struggle to go through, and then to put your child into someone else, and to have this trust that they're going to take care of your child,
Mhm.
and grow them, and they're going to be perfect. It's hard,
Yeah.
and then this baby comes out, and this is your baby. It's you're gonna feel it. You're
Yeah.
gonna feel it. There's no way that you can't. And
Yeah.
you're gonna bond. Your baby doesn't have to grow inside of you to be your baby.
Mm,
It doesn't. They don't need to
yeah.
grow inside of you to be your baby. At all.
Yeah.
And even, and then the other part is true too for our carriers. Our carrier, she was like, I miss him, but like a nephew. she's
Uh-huh. That
she's
is like the best descriptor.
she's like, I love him, but he's not my baby.
Yeah.
Like she knew. And I was looking back at pictures today, actually, kind of in preparation, and she had tears, but she had tears when she was hugging me. She didn't have
Mhm.
tears when she was holding him. She didn't have tears when she was like looking at him. She had tears when she was hugging me,
Yeah.
because of what that meant for us together, and
Yeah.
that moment of what that meant. Because it wasn't that was her baby. It was that what she was doing for us. And so
Mhm.
he wasn't hers, and she knew that.
Mhm.
And
Yeah.
because he was mine. he was mine. He was my baby. And you feel it. It's crazy. It's crazy.
Yeah. No, for sure. I mean, that moment was just like, that's the why. That's the why women choose to do this. And,
Yeah.
that's that.
Mhm.
And that moment is
Mhm.
exactly, I think to your point, right? Like, you
Mhm.
had that instant connection. And also, if it's delayed a little, that's not
Mhm.
bad either. Everybody
Mhm.
has that unique
Oh,
story.
yeah.
Everybody has their unique way of building their
Oh, yeah.
family. And it just, there's no
Yeah.
wrong. There's no wrong in it at all.
Nuh-uh.
Yeah.
No, and for us, it's so different. It was, and coming from this perspective, and I had a lot of people, ask me like, how were you with everything? Like that, because being an OB-GYN, like I do have a unique perspective on how this is and
Yeah.
stuff. And so, um, I think it's made me a better OB-GYN. I think it's made me
Mm.
be more understanding, in different ways.
Hmm.
To women, just in general, going through this, going through
Yeah.
fertility, going through just normal, delivery and stuff. It's just different. I don't think I do not feel anything negative to the way that I had to have my child. Like,
Hmm.
this is exactly how it was supposed to happen. And I'm so thankful that we were able to do this, because there is no, there's no other way that this could have gone. Like, he's
Yeah.
perfect. It's wonderful. Hopefully we're going to have a successful journey again, and, get to do this again.
Yeah, absolutely. No, I
Mhm.
love that. I love
Mhm.
that. Okay, I have two more questions for you.
Absolutely.
My second to last question.
Yeah.
If there was any advice, again,
Mhm.
as an OB
Mhm.
to intended parents, and
Mhm.
even to surrogates, what would that advice be, as you're kind of in that pregnancy part of the journey?
Communicate.
Communicate.
Communicate with each other, communicate with your OB. And that goes for, the surrogate, and that goes for the intended parents.
Hmm.
Communicate with each other and communicate each with the OB, and don't be afraid to. Um,
Yeah.
this is a unique situation, and be excited about it. Communicate. This is
Mm.
your chance as the intended parent. This is your chance to ask questions that you don't get to ask. Um,
Yeah.
yes, communicate. I think communication is 100% the most important, and it's the most important thing to do. And that goes from the day you meet the OB to after the baby is born. When
Hmm.
you're in the, postpartum, and you're with the, taking care of the baby, because you'll have, maybe the OB will come and visit you. Usually they do. I know ours did. When you're in there taking care of your baby, your brand new baby, ask questions,
Yeah.
communicate with your carrier. How is this going to look? That kind of stuff. But communication, 100%.
Yeah.
Mm-hmm.
No, that's perfect. That's
Yep.
perfect.
Mm-hmm.
Okay, my last question for you, and it's a fun
Mm-hmm.
one.
Yeah.
As you probably know from really just every phone call that we ever had, I am always holding a cup of coffee, or I guess in this
Mm-hmm.
case, it is tea. I will say I diverted, but
Mm-hmm.
generally speaking, some sort of caffeinated beverage is in my hand. And so I always love to ask the question, what filled your cup today? Literally or figuratively, what has been the thing that has filled your cup?
So literally, I had right now it's water. Um,
Good for you.
I know, right?
So good.
My LVN, my nurse did it. Um, it was not by choice, okay? Because I will tell you that I did have some coffee, but I did make myself a London fog today, which was quite lovely. Yeah, right before our call, I
Lovely.
had a London fog. But no, what filled my cup, I think figuratively, was just, I think, looking back at preparing for this, one,
Yeah.
being able to do this, because I forget how lucky I am to be in this position, um,
Mm.
taking care of women, and hopefully taking care of more women doing this. But getting back to looking at my pictures and seeing, you have to go back over the years, to see the
Yeah.
pictures from before, and just getting to see my son as over the years and growing, and he's turning into such a fun little guy, and
Mm.
getting to see those little snapshots today, I think just really, spend the day, spending a few minutes like looking at that beforehand just
Yeah.
really filled me up, and realized like how lucky I am to have that little guy, and hopefully have another one. So
Yeah, for sure. Life doesn't stop, and it's
oh
so
my God, I
fun
love
to be able to just get to like take a
it.
pause
So
and
cute. I
yeah.
love it.
And not for anything, but he is like particularly adorable.
He's
So,
he's
yeah,
a precious little guy. He is,
he
and
is.
he's a good one, man. He's a toddler, so I don't, we're doing that, but
Oh, yeah, sure, there's those days, but
he's
at least he's
fun.
cute all the time.
He is cute. He's a cute little guy. He is a cute little one. Funny, and he's got a personality. He definitely has a very big personality, which I'm thankful for, that I think that will come in handy when he gets older.
Oh,
So
for sure.
it's
For
hard
sure.
now, on occasion, but I think it's gonna serve him very, very well as he grows
Mm-hmm.
up. So
No, that's the good that every mom needs that mantra, I feel
mm,
like. Just or every parent really just
gonna
needs
work
that
out.
mantra of like, yeah, this will serve you well later. This is
Mhm.
worth it.
I need this. You need
Yes.
this.
Yes,
I can
absolutely.
suffer. I can suffer through this. This is going to serve you well. Like,
This will serve you well.
oh, for sure. For sure. He's my little bear.
Oh my gosh, I love it. Well, Audrey, again, seriously, thank you so much for doing this. Thank you
Absolutely.
for just your education and your, just beautiful perspective of getting to be able to look at this from all of the different sides. And so, again, I just really appreciate this, and sending you all of the baby dust and all of the good vibes.
Soon, hopefully. Thank you.
Soon.
Absolutely. My pleasure.
Thank you so much for joining us on this episode of Me, You, and Who. We appreciate your time and hope you enjoyed our discussion today. As we wrap, we would like to remind you of some of the ways that you can stay connected with us and be part of the Me, You, and Who podcast community. Firstly, if you haven't already, make sure to subscribe to our podcast on your favorite platform. Hit that subscribe button so you never miss an episode and can stay up to date with our latest content. But that's not all. We also have an exciting YouTube channel where we share some bonus content, behind the scenes glimpses, and video versions of our episodes. Head over to YouTube and hit that subscribe button there as well. And don't forget to click the notification bell so you'll be the first to know when the new episodes go live. And for more exclusive updates, engaging discussions, and a chance to connect with fellow listeners. Be sure to follow us on our social media accounts. You can find us on Instagram, Facebook, and TikTok at Create a Happy Family. If you're interested in finding out more about creating a happy family, please visit us at www.createahappyfamily.com. Thank you again for being part of the Me, You, and Who community. Your support means the world to us. I can't wait for you to join us next time as we continue to share stories and journeys of creating happy families.